I have no doubt in MSI high immunotherapy is the most successful treatment. I think the question is not, is it immuno versus chemo? The question is, what immunotherapy do we choose? And right now we have two options, pembrolizumab, nivolumab, and ipilimumab combination. I would never give nivolumab alone because of all the data, never side-by-side comparison, but the combination seems to be consistently better. And when you choose IPI at the right dose with 1 milligram every 6 weeks, the toxicity is not different than nivolumab alone. So I'm very comfortable with the nivo-IPI combination. The question is, we don't have the statistical power since comparisons were not done. Is this combination better than pembrolizumab? Is it the same? Just looking at the data presented at ASCO this year is 30% progression of disease as best response with the first CT scan is a little bit worrisome because we don't see that with nivo-IPI, also recognizing that this is a much smaller study. But the 30% progression was seen in other later lines of treatment with Keynote 159 and 164. So I think this gives us a lot of ideas in order to better understand what immunocombination is the best for this patient population.
Turning a cold tumor into a hot tumor is kind of the holy grail of really developing immune therapy right now. And this goes beyond the question MSI high versus MSS. There's some data that we've seen over time across the landscape of solid tumors, that sometimes combination, let's say, of checkpoint inhibitors, PD-1, PD-L1 inhibitor plus chemotherapy can actually turn a otherwise cold tumor into a hotter tumor, likely by releasing neoantigens, tumor antigens in the environment, and combination of therapy plus immunotherapy in PD-L1 low tumors seems to be more effective than just chemotherapy, than just immunotherapy alone. Then we've learned that combination of immunotherapy like checkpoint inhibitor combination, PD-1 antibodies plus CTLA-4 antibodies, ipilimumab, nivolumab, for instance, can be interesting and can potentially turn some of the colder tumors into hotter tumors. I still believe this is not the one-size-fits-all treatment for cancers. I do believe, from all the data we've seen, we need an additional modulation. And it could actually be that different, even in one cancer type, different patients need different approaches to activate the immune system. So the idea right now is to really generate an immune profile of tumors before treatment, seeing what angle do we need to use in order to turn these tumors from cold into hotter tumors recognizable by the immune system. This could be a very individualized treatment approach.
I think the way to move forward with immunotherapy in microsatellite stable tumors is really combination treatments. Now, this could be other immunotargeted drugs like OX40 or LRG5. It could be many different ones. I think there is a proved synergism between the anti-VEGF strategies and immune checkpoint. The data in HCC with BEV and Atezo are amazing. It is approved in first line, the highest response rate. So I think the anti-VEGF strategies with immune checkpoint makes a lot of sense. The reason is that anti-VEGF really modulates the polarization of the macrophages, which play a significant role in the immune response pathway. So VEGF is a part of an immune response through the macrophages polarization from M1 to M2. And here, I think, is a potential understanding that this combination may be very helpful. I think the most data we have is actually on Rego-Nivo from Japan, where we saw in this patient population 36% response rate. This is unheard of in refractory patients. But I think what is even more exciting is when you look at the gastric cancer cohort, there are 44% response rate. And in these patients, there were patients who were previously treated with immune checkpoint inhibitors who responded to this combination. So I think you can overcome resistance to immune checkpoint with Rego-Nivo combinations, which gives us some clue that this may be a promising combination for patients who are usually not candidate for immunotherapies. I think we still need to learn who are the patients who benefit from this combination, because I think one of the discussion points coming out of Rego-Nivo from Japan is that the patient selection in Japan may be a little bit different. Patients there have a less tumor burden, maybe have less tumor involved in the liver, more in the lung, and these are the patients who may benefit more. We are going to learn much more. There are many clinical trials going on with TKI inhibitors of the VEGF pathway and immune checkpoints. So within the next year, I'm sure we're learning much more what the efficacy is, and hopefully also who are the patients who benefit the most.